Hello, good morning. So my name's Miguel, if you haven't met yet, but I'm excited to talk to you or about this topic today and give you my senior lecture. So I'm going to start off with a case or a scenario, I should say. Basically, you're working in CCT, and in Prospect Park, there is a large outdoor event, over 1,000 people in attendance, and then there's an active shooter who opened fires into the crowd. You get a notification on the red phone that says that there's been an MCI, there's multiple unstable patients, victims on their way to the hospital. Within a couple minutes, you actually get a car pull up to the front, and there's three victims inside. The first person is a 23-year-old male with a GSW to the right upper extremity with brisk bleeding. There's also next one's a 38-year-old female with a GSW to the chest. She appears anxious, tachypnic, minimal breath sounds on the right. And then there's a 15-year-old male with a large head hematoma after trying to escape the scene. He fell and hit his head, but no LLC and GCS is 15. So as you start trying to evaluate them and resuscitate them, then you get an ambulance that comes in with another three patients. So the first will be a 44-year-old male. He has a GSW to the head. He's unresponsive and pulseless. Next person is a 32-year-old male who fell while running, was trampled, has a right lower leg extremity deformity, and has no DP or PT pulses in that extremity. And then there's like a 29-year-old female who's covered in blood, screaming, but there's obviously no obvious signs of any injuries or bleeding. And as the next hour progresses, you constantly get more and more patients, and you just have to quickly realize that this situation is getting overwhelming. Um, so I don't want to make this very anxiety inducing, but this is something that can happen. And so that brings me to what I want to talk about in this lecture is mass casualty incident response. Like, what do you do in the ER when you get a large influx of patients from MCI event? So I'm just gonna plug the pit. I know we've been talking about it a lot recently. The last episode was actually had to do with the MCI, and I actually liked a lot of the ways that it depicted how they were preparing for it and how they are running it in the moment. There were some things that were exaggerated, but for the most part, I thought it was a pretty good depiction. So I highly recommend watching it. These are just my objectives, what I'm going to be talking about today. But I'm first going to really start off with like just a definition, like what is considered an MCI? MCI is basically when there are multiple victims in a location that overwhelms the local healthcare system. So this can look very different in a rural setting. It could just be like 3 to 4 people in a small rural hospital that will overwhelm the hospital. But here in New York City, where there's multiple hospitals in the area, an MCI would have to be in a larger scale to be able to overwhelm all the hospitals that we have in such close proximity. And just to give a little bit of background, in one of our more extreme MCI events that we've had here in this country, on October 1st in 2017 in Las Vegas, there was an active shooter event who was shooting into a crowd of 22,000 concert goers. And between 10:05 and 10:17 p.m., a total of 12 minutes, there was 61 people killed and over 800 people injured. The majority of them were injured via GSWs, but a lot of other ones were just like blunt trauma related to the chaos that ensued afterwards. This is just an image of the location. Shooting actually occurred in the top left corner from Mandalay Bay through the windows directly into this event space outside of the hotel. And then this is just a little bit of statistics. So on the map, I marked the location of where the shooting occurred. And then you can see in the red dots are all the hospitals surrounding the shooting location. And there was actually what's interesting is an unequal distribution of where people presented to. So UMC is the level 1 trauma center in Las Vegas that has the most capabilities and most resources to deal with them, but they ended up not receiving the largest amount of patients. In fact, most people presented to Sunrise Hospital, where in the course of a couple hours, they actually received over 200 patients. Um, and then this is, I couldn't find any more updated information, but this is data from the FBI, just showing that active shooter events are increasing from 2000 to 2013. Not all of these are MCI events, but considering that the trend of active shooter events have been increasing, then um, there is a higher likelihood that we might end up working in during an MCI event, and we need to know how to approach it and deal with it. So the moment that you realize that there is MCI, whether it is from a pre-notification or you start receiving multiple victims unannounced, it's imperative to activate some sort of like MCI code. So try to overhead page it with plain language so that everyone in the hospital is aware of what's going on and sort of activate whatever resources they have, whether this can be operating rooms, the blood bank, medications from pharmacy, as well as being able to notify the administrator on duty or like any administrators of the hospital. So this would be like Dr. Youssef, Dr. Benson, because they can actually focus on a lot of behind the scenes support to be able to support you being able to manage and treat all these patients. And there ideally would create some sort of incident command system and separate the roles um, to have a robust response. In the ER specifically, there needs to be a triage system that will evaluate all the patients and risk stratify them, as well as creating zones for where the sickest patients goes and where the walking wounded will, as well as organizing a good like resuscitation team. Um, and then finally, the resources. So in MCI, you're going to have a limited amount of resources. So you just have to figure out how to best utilize the staff, the supplies that you have, as well as the space you have available. So the first part of any of these events is patient arrival to the hospital. So in multiple events that have happened here in the United States, not the majority of patients do not present to the hospital via EMS. As the scene is usually chaotic and usually there is no like sort of like triage system or location control of the event because everyone's trying to leave and escape. And so people have come to the hospital via taxis, Ubers, in the back of police cars, as well as via EMS. And sometimes they're carrying multiple patients in each one of these vehicles. Because of there is a disorganized approach to the hospital, they don't present to the hospital that might be best equipped to manage these conditions, and they may not be presenting to the right location of the hospital. So it'd be imperative to notify hospital police to try to close down any extra entrances and try to direct all traffic to like one location where all the patients can be taken out of the vehicles and start triage. Hospital police should also be able to um, uh, direct any family and friends that are uninjured to another designated location. That way they'd be away from the patient treatment area, and then they can receive any sort of updates as they come about. And then they can prevent any media from entering the hospital. Um, and then triaging. So once you did all the patients to this one location, there should be someone with experience to determine who is sick, unstable, or versus the very stable, and like determine who needs to have treatment first. So there's these tags that can be attached to each one of the patients, and it ranges from black to green, where black is basically they're already dead, there's no point in doing resuscitation, versus green, which is extremely stable, they can wait to receive treatment. There is a way of using these tags and actually rapidly registering them into the EMR. I know Downstate has about 100 active MRNs for an MCI situation where they can just rapidly assign each of the patients as they enter an MRN, and so there won't be wasted time to input all of them into the EMR. But I would not delay any patient's treatment to be registered, but this would help get everyone into the system as quickly as possible. And then you can also perform a couple just life-saving interventions in triage. There's very minimal things that you can do, but you could do tourniquets for any sort of like extremity bleeding. If there's a pneumothorax, you can do a needle thoracostomy, and this could buy a person time until someone's available to give them more definitive treatment. Then it's also very important to understand the space that you're working in. So this is a map of the ER at Sunrise Hospital and how they organized it. Basically, they put triage at the ambulance bay entrance, and then they separated the ER into 4 major zones. Station 1 being for their red tags, Station 2 for like their stable but urgent needing treatments, and more stable patients in yellow, and then our walking wounded in the green. And then they separated the staff into each of the locations, but the majority of people were assigned to Station 1 for the resuscitation, but had people assigned to other locations to just do temporizing measures for all the patients that are waiting for being resuscitated. So using this, I would say, like wherever you end up working, just make sure you're aware of the space you have in the ER as well as surrounding it, so that you know what spaces you can use to send patients and where to so like for us in CCT, you would probably still use that for resuscitation, but then maybe use PEDS for our more stable patients that can wait a little bit longer. So in the case of any MCI, or specifically with like Las Vegas, the hospital that received 200 patients, you can imagine if 200 patients arrived to Kings County within a few hours, we would very quickly run out of space. So what are the goals in terms of surge planning? So one of the things you can do is try to discharge as many stable patients as possible, discharge all the people from the ER as well as the floors that are able to leave, and then also transport any sort of patients from the floors to any open spaces on the floors, maybe even tripling up rooms to try to decompress the ER as possible. And then opening up as many flex spaces, such as like PACU, if there's any clinics that might have extra like space, such as in downstate, the clinics are right next to the ER, you can use that for maybe like walking wounded patients, and just have more space to be able to assess and treat all these patients. Then one of the most important resources that you will need is people, right? So you can imagine with 200 patients that you yourself won't be able to treat everyone, and you're going to need a lot of assistance. So if it's during the daytime, you can actually try to close all ambulatory clinics and reassign the staff members to help out in any capacity in the ER. You can also cancel any non-emergent surgeries so that you free up OR rooms, as well as um, having more surgeons, anesthesiologists available to do surgeries for those that need it. And then this will be more of the role of any sort of like administrators, just to try to call in more staff, physicians, nurses to come into the hospital. Although this is might take some time, especially considering after an MCI event, there a lot of roads or trains might be closed, so it might take a couple hours for reinforcements to come in. And then the resources that you have available. So everyone that comes in is, a lot of the people that come in will probably require intubation medications, opiates, any sort of medications, but there's only a limited supply in the Omnicell. And so there should be ideally a runner that comes from pharmacy that will bring in all the emergent medications to the ER, so that we don't run out of medications. Again, same thing goes for central supply, as patients might need chest tubes, intubation. You don't want to run out of the supplies. Something that was interesting that I was reading that occurred in Las Vegas is that they ran out of chest tubes, and instead they started using ET tubes as a surrogate to decompress or pneumothoraxes. And then if it's a traumatic MCI, there might be a lot of patients that will require blood transfusions, and so requesting that the blood bank would bring all O negative blood to the ED in the hospital to be able to resuscitate those that might require blood. And then things such as simple as like stretchers, like if they're as the patients are coming, you're going to need places to put them. And so trying to find as many stretchers, gurneys, wheelchairs in the hospital to be able to put patients that need a location to stay. So when it comes to treatment, this is basically, you're going to have to make a lot of modifications to how you normally treat patients. You might not have all your surrogate data points that you utilize to assess who is sick or not sick. You might not have an access to the most updated vitals. They might not be on a monitor, won't have imaging readily available, or blood work. So you really have to utilize your physical exam skills, assessing for airway, breathing, circulation, mental status, making sure use that to determine who is stable, unstable, and who needs the most emergent treatment. And then also having people that reassess the ones that were assigned to the lower acuity zones, just because as you are resuscitating the red tagged patients, it doesn't mean that the yellow or green tags may not become unstable. And so as you send the red tags to the OR or ICUs, after they've been resuscitated, some of those less stable patients might need to be treated emergently as they become unstable. There are a couple ethical considerations, because in these situations there are limited resources. You may not be able to meet normal standard of care for each patient if they came in individually on any other day. And so you have to determine and limit the amount of resources each patient get. They might not be able to get all the blood that they would normally get, or any sort of intervention such as going to the OR immediately. And this may inadvertently harm some patients with the goal of helping the majority of patients. And now, as you are resuscitating, it's been a couple hours, you're no longer receiving new patients. Now you start entering like the recovery stage. So it's important that once you get backup to come in to help out with managing all these patients, that there's also a consideration of like who's going to be on the next shift. Like you don't want to call in everyone and then there's no one to relieve them afterwards. And then as well as if any patients that are resuscitated or become stable and your hospital is still in surge capacity or overflowing, potentially transferring them to more to other hospitals that have capacity. And then there's gonna someone should be focusing on trying to identify all the victims and connecting them to any loved ones that are looking for them. A couple different special considerations I just wanted to bring up. If you are in a single coverage ED rural hospital, you are basically gonna not have a lot of backup available and not have a lot of resources. And so these situations can very quickly become overwhelming. And so activating or calling your administrators to call as many people in is going to be imperative, as well as once you stabilize them, transfer them out as soon as possible. You're going to encounter some similar issues overnight because even though you could be in an institution that has a lot of resources, a lot of things are closed overnight and you might not have more than like 1 or 2 ORs available. So it might take a lot longer to be able to get up to full capacity while you're waiting for people to come in. And then, oh, I apologize that you can't see one of these images, but some of these MCIs might be a result of any like bioterrorism, radiation, or toxins. If as soon as any of these are suspected, you must make sure that everyone has proper PPE. You create zones for like hot, warm, and cold for decontamination. You remove the clothing of the patients and shower them before they can come into the ER. And minimize any contamination to other areas as well as people. And specifically with toxins, if there are any sort of antidotes, then try to either call the Department of Health and if they have the antidote, they can ship them to the hospital. And finally, some mass casualty events can actually be mass fatality events where the majority or a large amount of patients have passed away, and then there becomes issues of dealing with all the bodies. This happened during COVID-19 where there wasn't enough more capacity to deal with other bodies and led to requiring all these trucks being outside of hospitals to store them. And then I just want to end with, if you end up in one of these situations, I want you to really focus on mental health afterwards, debriefing, seeking professional support, just because these can be traumatic and you don't want it to negatively affect you. And that brings me to my sources and the end of my lecture. But I do just want to summarize, it's in any of these events, it's very important to be extremely flexible. It's hard to give very specific directions or instructions for how to deal with them because each one is different. How you respond depends on how many patients they are and what resources you have available. So it's just always important to know what are your resources and how best to utilize them. And so, yeah, thank you. So I'm super grateful for being part of this residency, and I'm glad that I got so much support. And so the couple people I just wanted to thank have been my residency family. We've gone through so much together, and I couldn't imagine anyone else to do this with. I also want to thank my husband, who he's been my rock and has supported me through this residency. And thank you to all of my family. Basically my parents, my brother, as well as my in-laws who have taken me in as one of their own. Well, thank you. And that's the end of my lecture. Does anyone have any questions?